This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on LVAD. And with me today, my co-host is Dr. Mustafa Ahmed, Director of Interventional and Structural Program at UAB. We have also Dr. Jason Guichard, who's an advanced heart failure specialist with Prisma Health in South Carolina. And our special guest today, an incredible surgeon from Australia, Dr. David McGiffin, who's director of the heart surgery and cardiothoracic surgery program at the Alfred Hospital. So, gentlemen, welcome into this podcast. And this is actually very nice because here we are, Sunday afternoon, beautiful afternoon in Birmingham. It's dinner time in South Carolina, and it's breakfast time on Monday morning in Australia with Dr. McGiffin. So thank you very much for taking the time, making the time to discuss LVAD. So, David, I'll start with you. Can you explain to us, we talk about LVAD as a mechanical circulatory support system. What is LVAD? What does it stand for? And how should we explain to our patient what an LVAD is?
So an LVAD, or left ventricular assist device, is a form of mechanical circulatory support that really arose out of cardiac transplantation, the number of patients who were dying on waiting lists, and the history of ventricular assist devices used as a bridge to transplantation has a very interesting history. But the circulatory support community always knew that ultimately the goal was a permanent replacement device that would replace transplantation. Now we're not sort of quite there yet, but the role of ventricular assist devices in many countries like Australia is primarily as a bridge to transplantation or a bridge to decision. I just want to put a caveat on these terms. There is the terms bridge to candidacy, bridge to transplantation, bridge to decision, and destination therapy. That is, patients who are going to receive an LVAD as the final therapy because for one reason or another they can't have a heart transplant. I think we've got to be a little careful with those intention to treat definitions, because the reality is people may move from one of those intentions to treat to another because of the dynamic nature of heart failure and its treatment. And I think we should really get rid of those terms, and because those terms are really sort of regulatory terms, because we should just have there is an indication for an LVAD, yes, no. I think that's how we should be looking at it. And then a patient may be ultimately going to a heart transplant or maybe going to destination therapy. Now, destination therapy, of course, is widely used in the United States, but not used in Australia, because patients in Australia getting an LVAD have to fulfill the criteria for bridge to transplantation. Now, that's ultimately going to change, but that's the situation at the moment. Now, the ventricular assist devices had, as I mentioned earlier, had a very interesting history. They started out with these pulsatile devices, which had numerous complications. They were in very, very large devices, and a lot were extra or paracorporeal devices. That is, the pump was actually outside of the patient. But the whole situation of VADs changed when continuous flow technology came along, because nobody knew, could you live without a pulse? And then it was discovered, well, in fact, you can live without a pulse. But we've created this whole new physiology of continuous flow and pulseless patients without a pulse. And there are some downstream consequences of that, but it is possible to live without a pulse. We've actually this is sort of an anti-evolutionary trend. You know, for 700 million years, we've had a pulse. You know, and now we're becoming anti-evolutionary, and by taking the pulse away. So there've got to be some downstream consequences of not having a pulse. But anyway, the pulse, this continuous flow technology is wonderful technology, and has enabled many patients to get to transplantation who otherwise would not be able to be transplanted. They would have died prior to it. And there are patients now who have LVADs and living very well for many years with these devices.
So obviously you're talking about the tandem heart, which was the pulsatile. I mean, obviously LVAD has been going on for at least 20 years, but it seems like the evolution of it is progressed toward the HeartMate or the HeartWare LVAD, which is now being used these days, isn't it?
Yes, the continuous flow pumps, the HeartMate 2, HeartWare, and the latest one is the HeartMate 3. And the one that we use at the Alfred is almost exclusively the HeartMate 3.
So just to get into this a little bit further, and Jason, to pull you into this a little bit. So the reason you need a left ventricular assist device is because your left ventricle, the main pumping chamber of the heart, is failing and cannot no longer meet the body's needs, correct? And so how's that been over the last 20 years or so? How's that evolving now? At what stage? When does the LVAD conversation begin?
Yeah, that's a good question. So, heart failure is a progressive disease. So people are usually have an index hospitalization, with heart shortness of breath, dyspnea on exertion, lower extremity swelling, where the heart failure is initially diagnosed. Then medical therapy is started, various device therapies if needed, and patients can usually follow kind of three trajectories. One trajectory is getting better, which thankfully in this day and age of medical therapy is the majority of patients, with all of the medications in our tool belt, which some of them we've talked about on a previous podcast, including the SGLT2 inhibitors. Some patients don't really improve, kind of stay the same, kind of linger a little bit with doing okay at home, but still a little limited, especially with exertion. And then you have another group of patients that don't do well with medical therapy, and sometimes even unable to get out of the hospital, even with that initial hospitalization, due just to the weakness of their heart. There are some red flags that we look for, with worsening heart failure or patients that would technically meet criteria for LVADs. Kind of a simplified mnemonic, which is often used kind of in the heart failure world, is I need help. So the I stands for inotropes. So inotropes is a IV medication that helps the heart pump. To kind of classic inotropes is medicines called dobutamine and medicines called milrinone. If your heart is requiring an IV medicine continuously infused in your body in order to work, that's obviously a red flag. So these patients are very high risk, and would be candidates for what we would call advanced therapies, as a umbrella term for incorporating LVADs and heart transplantation. The second, which would be N, which is NYHA class. So usually NYHA class 3 or 4. So these are very symptomatic patients that are unable to go up hills, go up inclines, are very, very symptomatic with exertion, unable to do normal daily activities. Next would be E. So the I need help. E would be end organ dysfunction. So people that have worsening renal function or liver function, these are all high risk features of a weakening heart. Obviously the heart provides, flow to all the organs. So as the other organs begin to have issues, that's all kind of indicative of worsening heart failure. Next would be another E would be very low ejection fraction, usually less than 20 to 25%, which is one of the important reasons for getting an LVAD. The D is defibrillator shocks. So if you have a device and you are having lots of VT and VF, so ventricular tachycardia and ventricular fibrillation, those are high risk features for a weak heart. So that would be something to think about. Next would be hospitalizations, H. So one hospitalization in the last 12 months or greater than one would be a high-risk feature. Next would be edema or escalating diuretics. This is the another E. So if you're requiring high-dose diuretics to keep the fluid off you and we're having to constantly increase medications to get you better, that's a high-risk marker. L is low blood pressure. So if we're unable to get people on medical therapy or on medications to help their heart, that's a high-risk marker as well. And then P, prognostic medication. So, unable to titrate medicines to their goal doses are all high-risk features. So basically just describing someone with a weak heart that we're unable to use with medications or unable to improve them with medications. The next step in that process may be either LVAD or a heart transplantation.
So just to be clear, I mean, the LVAD obviously is not an artificial heart. I mean, what is the difference between those two?
So an artificial heart is where the heart is removed and replaced by a pump, which is usually a pneumatically driven pump, although there is being under development now a continuous flow total artificial heart. So there's two impellers, one for the left side and one for the right side, incorporated into a single can. So that's under development. That's called the bivacor. But the artificial heart is a pneumatically driven pump. But unlike the LVAD, where you keep the native heart in place, the artificial heart requires the ventricles to be removed.
So basically, we have a device, the LVAD, that really kind of helps the left ventricular, the heart, the pump, the main pump. Jason has described a patient population that really is needing help. How do we know whether this patient will evolve toward a transplant or whether is a candidate or not for a transplant? What kind of criteria do we have for this, or how do we decide whether this patient would be a good candidate to stay on LVAD and live with LVAD? How do we make these decisions?
Yes, this is a very important question that all advanced therapies committees, VAD and transplant committees, kind of struggle with. There are some kind of rules of thumb, so to speak. Some of the easy ones are if someone is, transplant, you have to be on a waiting list based on blood type and other markers. Sometimes the wait can be long. As we know, these patients can be very sick. And if they can't wait long enough for a heart transplant, that would be an easy indication for an LVAD. Because you obviously don't want someone struggling or dwindling away, and then they're too sick for a heart transplant, and then not be able to get the therapy that they need. Some additional things, at least in the U.S., to kind of decide between transplant or LVAD would be the indication that Dr. McGiffin talked about, which would be destination therapy, also called a bridge to life, which is kind of a more politically correct way of saying things. These are patients that will be on LVAD as permanent therapy. So for one or more reasons, they are not a heart transplant candidate. Some of the big things are age. So at least in the U.S., there are some cutoffs, some age restrictions. It varies by a transplant center. But generally speaking, the 65-year-old age begins to be kind of a cutoff for some transplant programs. Other issues would be ability, other systemic illnesses. So patients that have bad lung disease, bad kidney disease, or bad liver disease. So other organ dysfunction that could be prohibitive for transplantation. Sometimes these patients would be eligible for LVADs. And then, of course, as Dr. McGiffin was saying, the group of patients that are bridged to candidacy or bridged to decision, there are question marks with regards to some of their evaluation. So at that point, giving them an LVAD as a bridge to decision or bridge to candidacy will give you time to evaluate this patient fully in order to determine if they would be a candidate for transplant or not.
Let me just extend some of those comments of Jason. And this is a little bit country dependent too, because we don't have destination therapy in Australia. So once a patient gets an LVAD in Australia, retaining the VAD as a long-term option is really by default, because once you get a VAD in Australia, then you are listed for heart transplantation after you've recovered from the operation, unless there is some clear contraindication to transplantation. And that's that bridge to candidacy intention. And that is, there are times when we put an LVAD in when we're uncertain whether the patient will be transplantable or not. And if a patient's subsystems don't recover after the VAD, then by default, it's that patient is so-called destination therapy. The age cutoff of 65, of course, is chronological age, not biological age. And we will, occasionally transgress that age limitation. I should say probably the maximum age for a VAD or transplant is the age of the head of the department, by the way. But we will transgress 65 for patients who are biologically much younger than that. The other thing that will prompt us to move fairly quickly to transplantation would be complications arising from VADs. VADs are not free of complication. And one of them in particular is driveline infection and VAD infection. That really demands listing for transplantation. VAD infections are, for all practical purposes, not curable. There are reports of people being cured, but I think there'd be very substantial publication bias there, because there's a lot of people where these surgical procedures are tried, but they're not successful. And we can come back to VAD infection in a minute, if you like. The other issue is the right ventricle, because remember, we're supporting the left ventricle and we're relying on the right ventricle to function. Not normally, it does not function normally, but function adequately. That's the best you can hope for. The problem is that the right ventricle the right ventricle really, when an LVAD is put in, undergoes these changes in shape which make it much less efficient. And progressive right ventricular failure after an LVAD either requires a VAD to be put in on the right side or for the patient to undergo transplantation.
So going back on patient selection, the patient population we want to address, I mean, obviously, particularly when we think VAD, we think transplant. But I know in the U.S. there's over 100,000 people on the transplant list. There's about one new patient being added every day, and there's about 18 patients in average dying every day waiting for the transplant. So, is there a way actually? Are there predictors and way to refer the patient earlier to these VAD and transplant program? Do you have to wait to have a hospitalization for heart failure? Are there any kind of indices kind of tell us, as cardiologists following these patients with heart failure, we're trying to implement, guideline-based, medical therapy? Is there something we could kind of throw out there to say, hey, look, let's think about LVAD or transplant when we encounter certain problem? Just try to bring the patient earlier on to the transplant team, maybe.
Yes, I think most heart failure cardiologists would say that there's never really ever any too early reason to refer someone for advanced therapies. We would much rather receive the referral for someone too early than too late, because even if the patient is too early, we can still help with medications, help with prognostication, help with a little bit of education, and then always send the patient back to the referring physician. So thinking about when to refer, it's actually a fairly easy decision. Number one, it can't be too early. And number two, if you ever feel uncomfortable, like if these patients, you have that clinical kind of feeling, gestalt, so to speak, that, this patient's not doing well, that's always a good indication. And we've talked about some other kind of hard and fat or some easier kind of objective indications with the I need help. But there are various, clinical, biochemical, imaging, as well as hemodynamic markers for advanced heart failure. We could, go through some of those, pretty quickly. On the clinical side, cardiogenic shock. So usually someone in the hospital who is requiring medications or other mechanical devices to keep the heart supported. That's obviously an easy choice. We talked about hospitalizations. We talked about symptoms, NYJ class, advanced class type symptoms, inability to tolerate medical therapy, which we know is good for patients, rising creatinine or liver function tests or elevated BNP are some of the biochemical markers that are high risk. On the imaging side, a dilated left ventricle, which is also dysfunctional with a low ejection fraction, are always indicators. And then on the hemodynamic side, so patients with low cardiac output, which is just a kind of objective measure of how much blood the heart's pumping, are all kind of high risk markers, elevated pulmonary pressures. And then, of course, the Seattle Heart Failure Model, which is a score, a survival of less than 80% at a year. These are all patients that, definitely need to be seen by a heart failure cardiologist. But the easy answer to your question is, it's never really too early. We love to touch as many heart failure patients as possible to make sure that they're optimized, to make sure that they're, have the right prognostication. But then, most importantly, as a referring physician, if you ever feel uncomfortable, then that's always a good reason to refer as well.
Let me just emphasize what Jason said. It's never too early, and it's very important that a VAD transplant program has a patient on the books, so to speak, so the patient. And there are often things that can be recommended by a VAD transplant program that will be helpful to a referring cardiologist dealing with heart failure. And heart failure, I'm talking about chronic heart failure now, it isn't a sort of a progressive downhill course. It's sort of stepwise. And it's very easy for people to get sort of fooled about the trajectory, that a patient's really going downhill, and they don't quite perceive that that's happening. And if a patient's referred too late to a VAD transplant program, then often options are off the table because of subsystem dysfunction. So it's very important to get patients to a transplant program, VAD program, early.
Great. So we've talked about the LVAD. We've talked about the patient selection. And David, why don't you tell us maybe a little bit about the procedure itself? Let's say I'm a patient, I need an LVAD. What should I be expecting, coming to your clinic, and then as we go on to the procedure itself, coming to the hospital?
So here is a hardware pump, and the components of the hardware pump of a centrifugal pump are got this inflow cannula that's going to be placed inside the left ventricle to siphon blood through this chamber here where there is a rapidly spinning impeller. And then this is where the outflow graft is attached. An outflow graft is a Dacron graft it's like material. A Dacron graft then is attached to the ascending aorta, the main artery leading from the heart. And then there's this component called the drive line. So the drive line goes out through the skin and is then attached to a device called a controller, which is like a small computer, and the power source. And the power source can be the mains, it could be a cigarette lighter, could be batteries. So there are a number of sources of power. So that's the basic principle. And whether it's a HeartWare or a HeartMate 3, these are centrifugal pumps, as opposed to the axial flow pump, which is the HeartMate 2. They're very similar. So the operation is an open heart operation, so to speak, in that you need a heart-lung machine. Now, there are some centres that put these pumps in without using a heart-lung machine. That's a bit of a tricky thing to do, and I'm not all that convinced that that's a good thing to be doing. But there are some places that do it without a heart-lung machine. But we use a heart-lung machine. There are two approaches you can use. That is a stenotomy, so an incision up and down the front of the chest, or they can also be put in minimally invasively with a small incision under the left nipple and together with a small incision at the top of the breastbone. And the patient is placed on the heart-lung machine and a hole is cored at the apex of the left ventricle. And then what's called a sewing ring is sewn onto the apex of the left ventricle, and then the inflow cannula goes through the sewing ring, and then the sewing ring is locked in place. And
amazing. I've always wondered how you keep the cannula in such positions. So is the cannula locked inside the sewing ring, or do you? How is that kept in the sewing ring?
Okay, it depends which device, but you see there's a little hex screw there. See that little hex screw?
Yes.
Okay, so as soon as the inflow cannula goes through the sewing ring, then you just get a screwdriver which locks that hex nut. So that's the hardware. For the HeartMate 3, it's a different sort of mechanism that locks the sewing ring onto the inflow cannula. Then the graft is brought around the right side of the heart and then sutured to the ascending aorta. And then the drive is pulled by a tunneler through the abdominal wall and usually brought out either the left or the right side level with the umbilicus.
So how long does one of these operations take? What kind of what's the recovery like afterwards? And what's the training required to put one of these things in? Are these things only to be done in very few places by people who have done a lot? How does it compare to your standard heart operation?
Well, it sort of depends a bit on the condition that the patient comes to the operating room. Somebody who's been in cardiogenic shock and been on VA ECMO and a temporary VAD, and could be quite debilitated. Then recovery after this operation may be several weeks or longer. But somebody who, let's say, has got chronic heart failure, they're referred at an appropriate time, they've still got the physical reserves, they can be recover from this operation very quickly and maybe only in the hospital for a week or so. As far as training is concerned, there's no, at least in Australia, there's no formal training program for a VAD, but there are only 5 centres in Australia that put in VADs, including one children's hospital, and so there are very few VAD surgeons in Australia, but all of us have had considerable experience. So really, credentialing is hospital-based and really determined by the head of the unit.
So obviously, it's a complicated operation. We can count on probably 4 or 5 hour operation as well as a. Is that correct? Or
no. A straightforward LVAD it will take probably no more than 3 hours. But the issue often is the right ventricular function adequate or not? And that's one of the key decisions that has to be made during the operation. Because if the right ventricle if the function is not adequate, then you've got to do something about it. There is absolutely no point in sending a patient back to the intensive care unit with a struggling right ventricle, because that's not going to work. Because what happens is the VAD flow starts to fall, fluid is given, then the kidneys fail, then the liver fails, and the patient's unlikely to survive. And so what we do, and probably most centres do, we use a temporary right ventricular assist device if we have any concerns about the function of the right ventricle. Now, there are lots of ways of doing that, but the way we do it at the Alfred is we put in a temporary device. So we have an external pump, what's called a rotor-flow. The one we use is a rotor-flow. We put a cannula up to the right atrium through a femoral vein, and then we put a graft onto the pulmonary artery, and then we bring that out through the chest wall, and we put in a cannula into the graft, and that's the return line from the external pump. And we keep that in for as long as we are concerned about the right ventricle. Let me just re-emphasize, we're not after normal right ventricular function. That is not going to happen. We're after adequate function. And then when we think that the function is adequate, then we remove it, and that's a simple means. We just pull the cannula out of the femoral vein, the access line. Then the return line, we just pull the graft out of the chest a few centimetres, cut it off, oversew it, and let it just retract in, so we don't have to open the chest to remove the temporary RVAD.
So it sounds like some patients require almost like a right ventricular VAD, as well as the LVAD, but how frequently does that happen?
Okay, so that's correct. The patients with the very worst right ventricles may require an LVAD plus off-label use of an LVAD in the right-sided position. Now, as far as the temporary VAD is concerned, the usual sort of frequency that is used is probably about 10 to 15%. Our use of it at the Alfred is about 30%. And I make no apology for that, because we have a very, very low threshold for using temporary VADs, because there's no downside to using a temporary RVAD, but there's a lot of downside to not using it when you need it. Now, the very, very worst right ventricles need an additional RVAD.
You're this patient, you've had your procedure, you go back to the room. I guess you should expect, a week or two in the hospital, and then probably go to a rehab, center. Tell us a little bit, and maybe Jason, you can pitch in, what goes on with, obviously the family, the support.
It's obviously life-changing for both the positives and the negatives. So we can, talk about the positives first. So we know that there is a significant survival benefit with LVADs, and we know that there's a significant quality of life and functional improvement with LVADs. So the survival with an LVAD is about, in the kind of the modern era of destination therapy, is about 74% at a year. Now compare this to about 25% without an LVAD. So very significant improvement from 25% to 74% with an LVAD. And of course, that's compared to the gold standard, which is indeed heart transplantation, which is about 88%. So as you can see, survival is definitely much improved. And in addition to quality of life scores, including 6-minute walk, various questionnaires are all improved as well. So quality of life, survival, all without an argument improved over medical therapy in patients with LVADs. Now, I tell my patients for adverse events with LVADs, we've tucked up procedures, driveline infections, so the power cord, so to speak, that exits the skin is a chance for bleeding and infection. So you have to be careful about keeping that line clean. So that's going to be something that patient and their caregiver is going to have to be mindful of. There's mucosal bleeding. So both nosebleeds and GI bleeding is a very common complication of LVADs. Blood is made thin with an LVAD. You have an artificial device that the blood doesn't like, so your blood has to be made thin for that reason. The next would be pump thrombosis or embolization, which was a huge issue with some of the earlier devices, not so much with the HeartMate 3, but something that has to be kept in mind. And with that thrombosis and embolization, of course, strokes are always a big issue. So ischemic strokes from thrombosis. So as everyone knows, strokes are bad. That can be a catastrophic complication from LVADs, including hemorrhagic stroke. So just like the mucosal bleeding, your blood is made thin, your body physiology has changed with an LVAD, so you have increased chance for having hemorrhagic or bleeding strokes. So those are all the complications, or the majority of the complications I've had, even though you're able to be more functional, including playing with kids and grandkids and golfing and sometimes even going back to work. One of the biggest things to talk about is caregiver fatigue. Most programs require an LVAD patient or a candidate for advanced therapies to have a caregiver, so someone that would be with the patient 24/7. As you might imagine, caring for someone 24/7 can be problematic for some, especially if they work or have a busy lifestyle themselves. So there's definitely some, relationship changes, family dynamic changes, patient and caregiver changes that are all, important to evaluate and important to educate and anticipate before the implantation of an LVAD. And caregiver fatigue is a real issue and can be something that needs to be addressed early so as to prevent it from happening, because it can be, obviously deleterious to both the caregiver and to the patient themselves.
So you mentioned, obviously, the medication. These patients are on aspirin and anticoagulation, I suppose mostly Coumadin. A lot of these patients will still need their heart medicine. How about hypertension? How do you measure blood pressure in someone that doesn't have a pulse?
Yes, that's a great question. So yes, more and more information has come out now that we have longer term data with LVADs, and that is true. So we have learned that indeed continuing medical therapy for LVAD patients actually is beneficial. So sometimes a lot of your heart failure medications are continued, which is actually the right answer for a lot of your medications. As patients know, these medications can lower your blood pressure. So checking your blood pressure and monitoring your blood pressure can be a little bit tricky with continuous flow devices and patients that have no pulse. So your blood pressure is measured by healthcare staff that are familiar with these devices and how to measure blood pressure. It's generally done with a Doppler ultrasound machine, where you blow up a blood pressure cuff until the sound of the whooshing sound of the continuous flow device is stopped. And then as you release the pressure, that initial pressure where you hear the blood pressure is generally believed to be your MAP, or your mean arterial pressure. And that is the blood pressure of the patient. And we generally like that number to be less than 90. We've learned that through some studies, although it can be somewhat device dependent, but generally speaking, we like a MAP less than 90. So generally between 60 and 90 is kind of the window that we shoot for patients as far as blood pressure management with LVAD.
Sounds good. Now, let's say we're out of the hospital. My patient has had an LVAD. He's going to have obviously many questions. I mean, what is a life with an LVAD? I mean, what kind of exercise can I do? Can I have kind of a normal life? Can I bathe or shower? Can I travel? What do you tell them?
Yes, I would say, we do these things to get people, back to life as usual. Of course, there are going to be some changes. Lots of patients go on with their normal daily activities, including even going back to work and traveling. There are some, like we said, restrictions. Anytime patients travel, they need to identify an LVAD center that they would go to if they weren't having issues. So doing a little bit of homework before you travel is always smart. And generally speaking, either your LVAD center or the patient themselves will contact that LVAD center where they're traveling to make them aware that you're present in that area if there were any emergencies. You have to protect the drive line. So there is a special way that you shower in order to protect that drive line so it doesn't get moist and infected. And of course, as you might imagine, no submersion. So no swimming, no hot tubs. And generally it's recommended that there's no no boats, although cruise ships are generally, believed to be okay with proper precautions and education. So these are, what we always aim is to get people back to life as usual as much as possible. That's the whole reason why these things exist, to improve quality of life as well as survival. I know that there was a question about how long these devices last. These mechanical devices actually last pretty much forever. The main thing that would stop the devices would be either the patient expiring themselves, or if there was some complication within the device, whether that be a pump thrombosis or something else. But the device, if left to its own abilities without any complications, theoretically goes on forever, especially the frictionless or fully magnetically levitated devices that have no bearings. There would be really no reason for them to stop. And there are patients that have been on LVAD therapy for greater than 15 years. In the absence of any kind of complications, they are workhorses. They work forever, essentially.
Oh, this is great. So you really can live a normal life, pretty much a normal life with certain, adaptation. You can travel, you can exercise. I have some patients that play golf, with their LVAD. They're driving, everywhere. And even they have a normal family life with intimacy. So, David, maybe we could kind of look into the future and tell us what is in reserve. I mean, what are we studying now? What should we expect within the next 3 to 5 years with the LVAD development?
So the goal that the VAD companies and everybody involved in VAD implantation wants to see, and that is elimination of drive lines. So a totally implantable system so that driveline infections would completely disappear. Driveline infections have a 10 to 20% incidence. And as I said previously, they are, for all practical purposes, not curable. And the only way of dealing with it is VAD removal and transplantation. But living with chronic infection has some serious issues that having a VAD infection is actually a risk factor for having a stroke, either a hemorrhagic stroke or an ischemic stroke. So there are really important consequences of having a VAD driveline infection. The problem with eliminating the drive lines is that you've got to have a very, very reliable transcutaneous energy transfer system. Now that there are systems that are being trialed now experimentally, and one is actually being trialed clinically. And I know of 2 patients in Europe that have totally implantable systems using the coplanar energy transfer system, so that they have a big coil in the right chest beneath the right lung, and then an external coil for transducing energy. But there are concerns about the reliability of this system. And this system actually has a little external plug sitting on their skull. So if the system failed, you could plug the patient in to external power. So that really just demonstrates the concerns about the reliability of the system at the moment. So a fully implantable system is probably 5 to 10 years away. There is a lot of work being done on much smaller pumps, patients that have heart failure who don't really require a durable LVAD, but may benefit from having another litre per minute of flow. So these intraventricular pumps that could be implanted potentially percutaneously into the ventricle are currently under investigation. So these small pumps could really have a very important role in managing heart failure. So I think they're the big ones. One of the issues is about pulsatility. can we obviate some of the problems of not having a pulse with a pulsatile device? So there are no pulsatile devices at the moment. Now, the HeartWare and the HeartMate 3, they have some pulsatility, but that's not giving you a pulse. That's just some pulsatility to wash the pump. That's there for washing reasons to try and prevent clots. But if a device had a pulse that simulated our own pulse, would that be beneficial? Nobody knows. I will say that as terrific as these pumps are, and as wonderful a job that they've done saving lives, patients still do not have the same exercise tolerance as somebody with a normal heart or a transplanted heart. They still have exercise limitations.
So a question for you, Dr. McGiffin, since you've worked extensively both in the US and Australia, what is it like, what's access like to such technologies? Is it, what's your thoughts on that? You're obviously over here for a long time, and are these things equally accessed by the population? Are they not? And how does that look in the US, the rest of the world? Just what's your perspective on that?
Well, there's no perfect medical system. It's when you talk about which country has the world's best medical system, it's a case of which has the least worst. And there are, the top, let's say, 10 countries in the world that have, in terms of access and quality and cost, if you rank them, the access to these sort of devices is equitable and fair. So Australia is in the top 10, and everybody in Australia would have access to a ventricular assist device if that was indicated. Now, obviously, that there are reasons why some people can't get them because of geographic remoteness and all those sort of things that apply in every country. But in terms of if you're an Australian citizen or an Australian resident and you need a VAD, you will get a VAD.
Thank you, David. Maybe we could, obviously we know that LVAD, prolongs life and saves lives, and you can have a pretty good life, with that actually, and it can be quite long. What is the cost exactly, Jason, in the U.S. and maybe you could mention a few things about cost effectiveness of this technique?
Yeah, so as we've talked about in previous podcasts, cost is always a important part of any kind of therapy, and we openly discuss that. So at least in the U.S., the cost of effectiveness of an LVAD is destination therapy or bridge to life. The mean cost of an LVAD implantation is about $180,000. So this is quite a hefty price tag, as you might imagine, in the total 6-year total price tag. So the LVAD implantation carries a 6-year total price tag of about $750,000. So that is a significant cost, for a single patient over the course of 6 years. To kind of compare things for a heart transplant patient, the 10-year total price tag is about $1 million. So you can see LVADs are kind of slightly more costly or significantly more costly than a heart transplantation. So, all of these advanced therapies, both LVADs and transplant, carry very hefty price tags, which is why, we do a very thorough job on the front end, selecting candidates, because we want to be good stewards of our healthcare dollars, no matter what country that we're at. So that's why the rigorous evaluation process for any patient that's been through it, evaluating both, medical history as well as social and financial, history and caregiver support, is incredibly important, because we can put in these very expensive devices, but if someone doesn't have the resources, both social, financial, or even emotional or physical, to be able to handle these advanced therapies, then we really have done the patient a disservice as well as our health systems. So, although LVADs improve survival and quality of life, which we've talked about, they substantially increase lifetime costs compared with optimal medical therapy or optimal medical management. So we, as healthcare providers, need to be, judicious with the selection of patients and be very open and upfront with some of these costs.
Thank you very much. It seems like, we're treating not only the patient, but the patient and their family, because the family play a really crucial role in this therapy. Gentlemen, I'd like to thank you, Dr. David McGiffin from Australia, Jason Guichard from South Carolina, and Dr. Ahmed here in town, Birmingham. Thank you very much. Have a great day.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.